speakers coming up. We're going to do kind of, you guys may have dealt with this. Do I do surgery? Do we do biologics for these nasal polyp patients? So we're going to have Dr. Lanier come up first and kind of talk about biologics, and then be followed by Dr. Fulmer.
That's good. There we go. Good. Oh, boy, that's an easy polyp to see, isn't it? However, it's only on one side. Oh, wait a minute. They're going to cover that, are they? Jeez. Okay, so these are some, I'm known to be a little bit outspoken sometimes and maybe contrary. So I'm going to present you some things that may be a little bit controversial, but always need to be looked at. That's my disclosure. We're looking at the immunology of nasal polyps, maybe to understand how your role in this team is. First, what are they? They're a little pale gray semi-lucent bag-shaped protrusion from a sinus into the cavity or just off the turbinate wall. The big mark, of course, is the fact that when you take them down and look at them, they're just full of eosinophils. So therefore, they got to be allergic, right? Well, sometimes. Won't be that way necessarily in cystic fibrosis, but most of the time that's filled with eosinophils, and it has a definite structure to it. I mean, you look at the membranes and see what the internal portions are, and that's what a pathologist does when he sees the material. Who gets them? Men more than women. Increases after 40. Association between polyposis and aspirin sensitivity. It's strong. You need to ask everybody about aspirin sensitivity to NSAIDs. And some people just don't volunteer that unless you say it. It's more frequent in asthma and with aspirin-sensitive CS patients, associated sometimes with Church-Strauss or Cortageners. These are odd things. I mean, I've seen some. I've been around a long time. I don't know if you've seen yet a Cortageners or someone that has really a basic reason to have polyps. About 40 to 80% of aspirin-sensitive people have polyps. Yet polyps, only 15% of polyp patients has aspirin sensitivity. So there's a link, but it's not one-to-one. They're sometimes non-allergic, sometimes late asthmatic. Asthma also linked to pumps. So not always allergic. That's something that that was hard for me to see with that much material. The symptoms, of course, most of the time people are nasally congested. They can't smell. For some people, that's real important. For some, it's not. And I would tell you that when I'm talking about polyps, I will tell you that polyp is not a cancer. It's not a cancer. And sometimes they will stay stable. That's a controversial point. So, do they need removal? There's some people in this room I know personally that have had polyps for many years, and despite the best recommendations of all of us, continue to have them. Do they need removal? Depends on whether or not they are symptomatic. Now, can polyps be asymptomatic? Oh, yeah. You will see them on occasion that they're there, but people don't seem to mind them very much. I'm reminded, having been around a long time, I remember some old West Texas ranchers, ladies that were tough as nails, that had polyps for like 40 years, and I couldn't convince them that it was necessary to remove them. They said, well, it's okay with me. Okay, don't you miss smelling? Not particularly. All right, the one tool that we have, I think that's we don't use enough sometimes, the snot score, which was this tool that we use, which is oftentimes a prelude to deciding if somebody needs surgery, because it's a quality of life instrument also. Now, it only reflects the last few days, so it's not as useful for a long term. But I think when we do these scores, we often just see them in the chart. Yep, okay, there's a score, but don't really look at it at what it means. This is like an asthma, an ACT. You look at the scores. We don't probably pay any attention to this. This is reputed to be primarily a tool to decide whether people need surgery, but I think it's also some way that you need to follow with polyp patients and actually look at the scores when they're done, because they're done almost every time. So why not look at them as a trend? Now, do they need removal? Again, it depends on where they are and how much they are. Whether they're unilateral or bilateral, you're not going to have much choice if they're unilateral, according to, unless they're blocking things tremendously. So there was a panel put together that looked at this and decided whether or not, boy, I didn't realize that couldn't be seen. Pardon me, I hate when people say, well, it's too small to read. It's my fault. The question is, should intranasal corticosteroids be done rather than to be used in chronic sinusitis and nasal polyps? So there was a panel that decided whether that was reasonable or not. It is. All right. So the answer is yes, and I will get down here so I can read this thing. Okay, trust me, I'm going to tell you what it says. The conditions that can be important for shared decision making with whether or not the ICS is an intranasal steroid, a stent, and the delivery systems were beneficial. The cost and availability were there, and the moderate evidence of certainty for the safety of nasal steroids, but safety can vary amongst delivery options. So one of the things we had to do when we were doing research on some nasal steroid sprays, and I did a bunch of them, was that there was an instance of nasal septal perforation. And the reason that happens is that people don't use it right. A lot of times people come in and say, they say, what are you on? I'm this drug or that drug. Well, show me how you use it, and they'll do like this. Okay, now you will notice, you look and see the excoriations there. They can get it from the tip of the scope. I mean, that's just pressure on the area. So there's a rate of around 8% in study trials for nasal separation, septal perforation with a nasal steroid spray, just an over-the-counter, any of the common agents. In fact, we did a study with one of the nasal antihistamine products, and we had a nasal septal perforation rate of only 3%. And FDA turned us down initially because they thought we had cooked the books. Actually, what we did was we taught each patient how to use the nasal spray specifically before they went in, knowing that that was going to be a possibility, and reduced the rate from 10% to 3%. And had to go back and review the data with FDA. So it's not always that it's a cocaine habit or something else. Sometimes it's iatrogenic. Sometimes we do it. Okay, second. Well, let's see. Yeah. So the treatment for nasal polyps conservatively, you got a ton of options up there that you can use. This one here, the mometasone, is the only one that's ever had a clinical study associated with polyps, and it was useful. The second thing, the thing that has sort of all engaged us this last year, is this enhanced version where you actually use your power to provide a better coverage for the nasal steroid spray. It's really kind of innovative. Everybody kind of knew about this, but and it's a little bit difficult on occasion. You can't just hand this thing to somebody and say, "Here, do it." You gotta rub your nose and once you get it down, it's easy. But you gotta actually show people how to do that doggone thing. The ancillary medications used for conservative therapy, singular, Dr. Storms insisted I put that in there. I don't use it very often. Unless somebody's aspirin sensitive. Vitamin D. How many people here are using, are suggesting vitamin D to people? I thought so. Yeah, okay. So, and the reason is that's a very powerful vitamin for allergic inflammation. And it's been well shown that vitamin D is very important. I'd tell you to reconsist this. It's got immunomodulatory functions, and people don't think about it enough. Antibiotics, of course, and aspirin on occasion. But vitamin D was the thing I was really going to push out. So the second recommendations for this big panel with chronic sinusitis and nasal polyposis, that they suggested biologics rather than no biologics. In other words, if there's a question, use one of the approved mechanisms for medication and for polyps. I think that this is not terribly controversial if the polyps are, if they're bilateral and if they have actual impact upon the course of the disease. But they don't make a recommendation that about which one, but just that biologics are important. Dupilumab is, of course, the one that we always default to because of IL-4 and IL-13. And when you do that, you know, you see this pretty rapid. You've seen Dr. Gross here talk all day long about, or the last 2 days about Dupixent and its ability to rapidly induce functions. The question that we all have is the exit strategy for this. I mean, when do you stop? How do you know? And we don't know. That's the simple thing. Fast, its side effects are minimal. Omalizumab also has a contribution to this by stopping some of the actions of the staph that drives the whole process. So omalizumab was second in its polyposis evaluations, and what they did was to mine the old data that we had done from multiple trials and found it works. Which is the best biologic? Kind of depends upon who you ask, of course. The recommendations from the latest thing I could find, which is the best biologic for polyps. With these three, dupilumab, omalizumab, or mepo, the evaluation was that this was the first thing that compared different biologics with chronic sinusitis and nasal polyposis. And based upon the efficacy and safety, dupilumab was the best choice, and omalizumab is the second choice, although mepo ranked second in efficacy. It had a little bit more AEs than omalizumab. So for what it's worth, and this is the last thing that's been associated, that's been the recommendation from the International Archives of Allergy and Immunology. So you'll have to make your decision upon that. The third question was that the panel tried to see on polyps was say, well, is aspirin indicated? And is aspirin desensitization indicated? And they remarked that it's at least moderate as far as its effect, but that the risk of side effects were more than what many people were willing to take. Now, has anybody in here do aspirin desensitization? Yeah, okay, you do. Yeah, you would. You'd do anything. Okay, so you do that, George? Yeah, so what's the... Yeah, you, Richard? And a what? Well, I mean, this is imagine the mindset of the folks out in San Diego that initiated aspirin desensitization and aspirin challenge, where the first day when you take that, the first go-around, when you add the aspirin in, It ain't if you're going to get anaphylaxis. It's when. It's going to happen, you know. And so you got to be prepared for a certain mindset of going through that thing. And then, to top it off, to bring them back the next day and to give them the same dose. And they do fine. They do fine. So it's a little bit of a anxiety-provoking material for us to do in the first place. But if they don't sustain it, then you got to do it again. Yeah. 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 Xylitol? You mean Xyludin? Okay. All right. What? Okay. All right. Well, I have I talked with Tanya, who is the author of almost all the aspirin sensitivity things. She's just the queen of aspirin, not long ago. And the only people I did desensitize to aspirin are cops. Cop will do you what you tell him to do. They do. I'm telling you that when a cop says he'll do something, he'll do it. And if he, I mean, maybe that's, you know, prior Trump feelings about cops, but I respect those people, and they tell me what they're going to do. Just like when I see a farmer coming in, he's got a little manure on his on his shoes. I know he's going to pay his bill. You know, I don't mind a cowboy, and I love a cop because they'll do it. The problem is you just can't depend on it. Sometimes people forget. Sometimes they have a cold. Sometimes they travel. They stop, and you know if you restart it, you're going to have to go through that same terrible feelings and scare. I think it's worse on the doctor than it is on the patient. And so therefore, it's not useful very often. Now, here's a big thing, though, on polyps. Let me back. So you're going to have your choice about what you do. Prognostic reoccurrence of nasal polyposis removed, 40%. 40%. Sometimes polyps arise from the scars of the previous surgery. So, I mean, this is a disease process. We don't know exactly what is going to come out. But so then you got to say, well, is it worth it to do a monoclonal because it's going to be so expensive so long term? It kind of depends on what you think, and that's why we're going to get Dr. Fulmer to tell us the real story here.